So here we have minimally invasive decompressions. So this is for the person who has spinal stenosis, disc herniations, or something of that nature. So what we're doing now is called a modified microdiscectomy. It's a muscle splitting approach. So I put this tube down, which measures 18 millimeters in size. So it's smaller than a quarter. And instead of stripping the muscles off, typically we would make a midline incision up top here, come down to the spinous process, which is that little bump in your back that you can feel, okay? And we would pull all the muscle off the spine, all the way over to the side, so we could see this, okay? And if you're a big person, we've got to make a big incision because we're looking down into a small hole. Well, now we have these tubes that give us, this is a patient that I operate on who has this little channel that got me out to the nerve so I could take out the disc, okay? And when you take out that tube, the muscles just fall back over each other and they start to work again. And that's why you don't have as much of a problem with healing. This is what happens in a patient who has a big multi-level laminectomy. So this is an MRI. This is all scar tissue. Okay? So if all of that scar tissue is there, it doesn't function like muscle, doesn't function like ligament, and the patients wonder why, after having a laminectomy, they still have a lot of back pain. Again, it all goes back to the beginning. Your muscles, your tendons, and your ligaments. Here we've destroyed them. And I must admit, when I first started, I did this operation. I no longer do this operation. Okay? But this operation is still the gold standard, because very few surgeons do the operation that I do. So this is what the operation looks like. This is a little tube, okay? And we're working down through that tube to take out this person's herniated disc. Through that tube, which is 18 millimeters, after we get all the muscle off, we're looking at the back of their facet capsule or their lamina. So now I'm going to do the laminotomy, okay? I take a high-speed burr, my dental tool, and I burr that down, and now I'm inside the canal, okay? So again, this is through a microscope. You're looking down through the microscope. After you've done that, you now see the nerve. This is the nerve, and underneath that nerve is where the herniated disc lives. And so here, down here, I've reached underneath, and I'm pulling that disc herniation out. So here's a herniation coming out up top, and now I can inspect underneath the nerve to make sure that there's no more fragments. So we remove the disc, we decompress the nerve, and now we're inspecting to make sure that there's none of those extruded fragments. This young lady asked me about herniation before. So if you have a herniation that's extruded, it can be distanced from the disc level, and you have to go look for it to make sure it's not still there. And again, this is what it looks like after you're all done. So over a 3-year period, I did over 50 patients as outpatients for 1 and 2 level disease. Most common L4-5. Operating time just over 75 minutes, an hour and 15 minutes. All discharged the same day. So here we have some other techniques. This is taking the minimally invasive approach to decompression to the next stage. So when I try to teach other surgeons about doing minimally invasive surgery, they always ask me, well, why do I need to do a discectomy through a small incision? I'm already doing that. It's part of the learning curve. It's part of the process of learning a new operation. So now we have that small tube. And the previous disc herniation was for a younger person. Now we have the older patient who has significant stenosis. This is a disc. This is another disc. This is that myelogram. And you see how all the nerves are kind of clumped together. So typically the doctor would talk about doing a laminectomy. And when you did that laminectomy, these are called your facet joints out here. And we know that if we take down too much of the facet joint, that spine becomes unstable. And so then you either have that problem where you have all that scar tissue I showed you before, or the spine starts to become unstable and starts to slip. And after your laminectomy, they talk about going back, let's do a fusion now. Or they talk about doing it at the time. With minimally invasive surgery, you put your tube in down here, and that allows you to see this part of the canal. And then by tilting the tube, or wanding the tube, you then look across at the other side. And before you know it, you've done a bilateral decompression through a unilateral approach. Okay? So I do 1 or 2 of these a week. patients in their 70s, 80s, who come in the morning. I'll do 1 or 2 levels, and they'll go home in the afternoon or the following morning. So that a bilateral decompression allows us to see all of that. So what we're actually looking at is something like this. So here, again, through that tube, I'm able to look up and down in the spine. I'm able to take this probe, is coming through here, and is feeling over the other side. Okay? So what I've done is I haven't done anything to the top of this facet joint. So I don't have to worry as much about instability. So I can decrease the fusion size. Okay? So even in that 45 to 65-year-old woman with the L4-5 spondylolisthesis, very common, typically that's a fusion of L4-5. Depending upon the activity level, depending upon how much motion they have, today I will typically tell them, let's do the decompression alone and see whether or not it becomes unstable. See whether or not you have pain. Because most of the time they've had back pain for a while. They come to me because now they have leg pain that goes along with it.